Hippocrates once said, men think epilepsy is divine mere because they did not understand it. But if they called everything that they did not understand divine, there would be no end to divine things. Let's listen to a talk about seizures in ICU. It's my pleasure to invite Dr. K. Selva Perumal sir and Dr. P. Gayatri ma'am onto the dais to chair this session. Dr. Selva Perumal sir is a consultant neurosurgeon. He did his MBBS from Coimbatore Medical College and MCH at Madras Medical College. He is now a consultant neurosurgeon at Sudha Multispecialty Hospital, Erode. Dr. Gayatri ma'am is a consultant neurologist. She completed her UG from Guntur Medical College and MD and DM from PGI Chandigarh. She has published several papers in international publications. We welcome you both. Now I invite Dr. P. Gayatri ma'am to introduce and welcome our first speaker of the session, Dr. G. Vikramraj sir.
Good afternoon everyone. I would like to invite Dr. Vikramraj, post from DM from Madras Medical College and MD from General Medicine from Tanjavur Medical College, consultant at Sudha Hospitals, to give a lecture on seizures management in ICU.
Thank you, ma'am, for the kind introduction. Respected chairpersons, dear friends and senior doctors. At the outset, I'd like to thank the organizers for giving me this opportunity. Today, my topic will be about seizures in ICU. The agenda will be about an overview about seizure classification, status epilepticus, non-convulsive status, management of status, and a few words about NORS and FIRES. The difference between an epilepsy and a seizure is a brief temporary disturbance in the electrical activity of the brain, while epilepsy is a disorder characterized by recurring seizures, also known as seizure disorder. A seizure is a symptom of epilepsy. So going to the classification, the International League Against Epilepsy has classified seizure into focal, generalized and unknown, focal being with or without impaired consciousness. It could be motor onset or non-motor onset. And generalized, it will be either a motor or non-motor onset. A focal, local, partial seizures is classified into simple partial, complex partial, and a partial seizure evolving into a generalized tonic-clonic seizure. So this patient, he's having a seizure involving one side of the face. He is a patient with post-stroke seizures. And the next patient is having a seizure involving the left hand. This is a patient with hyperglycemia. And the third patient is having a seizure involving his right hand. All these are partial, simple partial seizures where the patients are preserved with consciousness and they'll be able to do whatever we ask them to do. The third patient is a patient of Rasmussen encephalitis, in which there will be an atrophy of one side of brain. And this is an autoimmune disease where it can be treated with IVIG or plasma exchange. Your simple partial seizure usually occurs from the primary cortices, which could be a primary motor or sensory cortex or visual or auditory cortices. And the seizure, EEG will pick up the focus of seizure from the areas. A complex partial seizure is one where there will be loss of consciousness. Patient will suddenly lose his consciousness. There will be some movements in the form of automatisms, posturing of hands and fidgety movements. This could last for minutes, even to hours, and there won't be any fall or tonic-clonic movements in such patients. The other patient is a boy who laughs. This we call it as gelastic epilepsy, which is due to hypothalamic hamartoma. A complex partial seizure is one which arises from the association areas adjoining the primary cortices. It could be a primary association area near a motor or a sensory, auditory, visual or olfactory lobes. Generalized seizures are one which can be classified this way as absence, atypical absence, myoclonic, clonic, tonic, tonic-clonic or atonic seizures. This boy who is cheerfully blowing a cloth, suddenly he will lose his consciousness with fluttering of eyelids, which lasts only for few seconds. Such thing can occur for several times a day. This is a typical absence seizure. You can see he has lost his consciousness and there is just a eye blinking scene. And the EEG will show typical 3 Hz spike wave discharges. And the other thing is a atonic seizure where the patient suddenly loses her tone with falling forward of her head or the whole of the body. This could lead to even fall and injuries, leading to head injury also. A myoclonus is one which is sporadic or repeated brief jerks of limbs. This is a boy with subacute sclerosing panencephalitis who has a generalized myoclonus. And this is a patient with focal myoclonus involving his hands. He is a case of metabolic encephalopathy. And asterisk is, we call it as negative myoclonus, which the patient will not be able to sustain a posture, and there will be momentary loss of tone, commonly seen in metabolic encephalopathies, especially renal or liver failures. A myoclonus in a hypoxic ischemic encephalopathy, this is a patient with post-cardiac arrest status who has been revived and put on ventilator. There will be generalized jerking of limbs. A myoclonus which is generalized in such a setting of hypoxic ischemic encephalopathy usually is a poor prognosis. And infantile spasms where there will be grimacing and stretching of limbs. This is a baby. This is in a setting of, we call it as West syndrome, which is a triad of infantile spasms, developmental regression, and a specific pattern of EEG. We call it as hips arrhythmias, which are chaotic brain waves. So etiology of a seizure and a status in a ICU could be because of a neurologic insult, particularly CVA, infection, head trauma, anoxic brain injury, neoplasm, etc., and a metabolic abnormalities such as hyponatremia, hypoglycemia, which are common, and a drug or toxins such as antiepileptic withdrawal, alcohol, etc. And a multisystem disease also could cause a seizure in an ICU. Going to status epilepticus, this is a medical and neurologic emergency. The overall mortality is between 17 to 26%, and 10 to 23% of survivors are left with deficits. So definition being a continuous or repetitive seizure activity persisting for at least 30 minutes without recovery of consciousness. We call it a status, but for practical purposes, we can't wait for 30 minutes. So when a seizure persists beyond 5 minutes, we call it as a status for our practical purposes. So classification being, it is either convulsive or non-convulsive. In an ICU setting, most seizures are non-convulsive and would be missed in the absence of EEG monitoring. A status epilepticus could be convulsive, non-convulsive. It could be partial, we call it as epilepsia partialis continua. It could be myoclonic status, or it could be psychological also. A partial seizures is one where there is, here this is a patient of CVT with right hemorrhagic infarct in the brain. There is a continuous seizure activity with loss of consciousness in his left hand. Here the patient improved with heparin and other medications. And this is actually a video from the video EEG lab. A patient suddenly developing a generalized seizure. You can see him developing a generalized seizure. Initially there is a tonic phase. Later a clonic phase. And the seizure will stop. And psychogenic status epilepticus, particularly in such patients, a pelvic thrusting, ictal eye closure, and ictal crying or pathognomonic, and EEG will show only muscle artifacts. The normal discharges will not be seen. Here is a patient in an OPD, actually. He is seen as if he is throwing a fit. He will see to that he doesn't get an injury. And this movement will last for even hours together till he gets exhausted. And typically movements will be very bizarre. There won't be any tonic or clonic movements. We call it as psychogenic non-epileptic attacks or a non-epileptic attack disorder. So hazards of status it can lead to neuronal injury or systemic disturbances if it lasts beyond 30 minutes. Neuronal being excitotoxicity, increased neuronal metabolic demand or blood flow, or increased mass effect or midline shift, and systemic disturbances which are outlined here, particularly rhabdomyolysis, which is very common following a prolonged status. Going to non-convulsive status epilepticus, if the level of consciousness is not improving by 20 minutes after cessation of movements in a status, or a mental status remains abnormal 30 to 60 minutes after convulsions, non-convulsive status must be considered and urgent EEG is advised. So this is a patient of viral encephalitis in an ICU with brainstem signs and on a ventilator. You can see that there is only a movement in her eyelids, but there is no other movement in any part of her body. But EEG shows a typical continuous seizure activity. So this is a non-convulsive seizure. The patient improved with anti-epileptics. So a non-convulsive seizure, is it a significant problem in the ICU? Yes. 35% of neuro-ICU patients and 22% of traumatic brain injury, 28% of ICH, 15% of SAH, and 44%, all these will have seizure, most of them being non-convulsive. And in pediatric ICU, 44% will have seizure, of which 39% is non-convulsive. Semiologic pattern need not be a motor activity. It could be a negative symptom such as anorexia, aphasia, mutism, amnesia, catatonia, coma, etc., or a positive symptom such as agitation, automatism, blinking, crying, delirium, etc. So EEG in an status epilepticus is very important. Normally we see periodic epileptiform discharges, which could be generalized or localized. This is generalized pediatric epileptiform discharges, and this is a periodic lateralized epileptiform discharges confined to right hemisphere. Going to the treatment of status, usually in the first 5 minutes, as soon as the patient starts to getting a seizure, we have to stabilize, time the seizure, assess airway breathing and circulation, initiate ECG monitoring, and collect sugar levels. If it is less than 60, give 100 milligram thiamine and then D50. If still the seizure persists beyond 5 minutes, intramuscular midazolam, intravenous lorazepam, or intravenous diazepam can be given at appropriate dosage and can be repeated. These three are the level A evidence as far as status epilepticus treatment is concerned. Other things are intravenous phenobarbital, rectal diazepam, intranasal midazolam or buccal midazolam also can be given. If seizure still continues beyond 20 minutes, we have to give either one of these three. It could be fosphenytoin, valproic acid, or levetiracetam as loading doses. If still the seizure continues beyond 40 minutes, neurologic injuries have started to occur. There is no clear evidence how to treat such patients, but usually we go in for an anesthetic agent and put the patient on ventilatory support. A status epilepticus that fails to respond to the first and second line therapy, we give midazolam, propofol, or pentobarbital infusions, and target is EEG burst suppression. So pharmacotherapy, usually the first agent, lorazepam, is the drug of choice, which is from this study, Veteran Affairs study, which was published in 1998, which showed lorazepam to be the first drug of choice. And this ESET trial, which was published in 2019 in NEJM, this is a landmark paper which showed that levetiracetam, fosphenytoin, and valproate as second degree drugs. All these three medications are equally effective in treating the status patients. We should know about the common medications that can lower the seizure threshold in an ICU particularly. You should be careful while handling these drugs. To taper a continuous infusion, this should be done beyond 12 to 24 hours after seizures has stopped, and a gradual taper. If there is a prior history of seizure to prior taper, we have to prolong it even more. Outcome mortality is 17 to 23% and morbidity is 10 to 23%. And few words about NORS and FIRES. NORS is nothing but a new onset refractory status epilepticus. This is a new terminology. Actually, it's a clinical presentation characterized by new onset refractory status epilepticus in a patient without active epilepsy or other pre-existing relevant neurological disorder, either acute stroke, brain mass or drug overdose, etc., and without a clear acute active structural or toxic or metabolic cause. Usually these are due to non-paraneoplastic autoimmune encephalitis or a paraneoplastic autoimmune encephalitis. These antibodies can be detected either in the CSF or in the serum, and treatment is usually IV immunoglobulin or a plasma exchange. And FIRES is nothing but a febrile infection-related epilepsy syndrome. It's a catastrophic epilepsy syndrome that strikes previously healthy children aged 3 to 15 years and has unknown pathogenesis and treatments. These children experience a non-specific febrile illness that is followed by a prolonged refractory status epilepticus. So with this, I conclude my talk. Thank you for your patient listening.
Thank you, sir, for an amazing presentation.
Strokes normally do not discriminate anyone by any means, and it can happen to anyone. But today, we're here to discriminate when, what, and how stroke happens. I'm happy to invite Dr. K. Selva Perumal, sir, to introduce our beloved speaker, Dr. S. Mohan, sir.
Good afternoon. It is my pleasure to introduce my beloved friend, Dr. Mohan. He completed his MBBS in Madras Medical College and did MCH neurosurgery also in the Madras Medical College. He has done a vascular fellowship in Japan Fujita University. He is currently a senior consultant neurosurgeon at Sudha Hospital, Erode.
Thank you, sir.
Mohan.
Yeah. Surgery for stroke. Before we move on to this topic, we shall briefly brush up some basics to have a better understanding. Stroke, we know, stroke is a medical emergency, and it is clinically defined as a neurological syndrome due to acute disruption of blood flow to an area of brain and corresponding onset of neurological deficit. This can be ischemic or hemorrhagic. The ischemic variety is the commonest and accounts for about 80%, whereas the hemorrhagic variety accounts for about 20%. Hypertension is the commonest cause of hemorrhagic stroke. About 20% of these need surgery. This is the blood supply of the brain, the circle of Willis. The Willis is formed by the two vertebrals joined together to form the basilar artery. The basilar artery quadrificates into two posterior cerebral and two superior cerebellar arteries. In the middle, there are the small perforators. They supply the brainstem. The anterior inferior cerebellar artery on either side of the basilar artery supplies the cerebellum. And this posterior inferior cerebellar artery arises from the vertebral artery and supplies the majority of the cerebellum. This forms the posterior circulation. In the front, the carotid artery divides into a bigger middle cerebral artery and a smaller anterior cerebral artery. The two anterior cerebrals are connected by the anterior communicating artery. This is called the anterior circulation or the carotid system. The carotid and the basilar system is connected by the posterior communicating artery. This is a very fantastic artery in that in case of ICA occlusion, this posterior communicating artery can provide blood flow to the middle cerebral as well as to the anterior cerebral artery. Same way, in case of any basilar occlusion, through the carotid, this PCOM can provide circulation to the posterior cerebral artery. And there are small perforators which arise from this internal carotid or the anterior cerebral and the middle cerebral artery. They enter into the respective anterior perforated substance and supply the basal ganglia. And from the basilar artery, small perforators, they enter and supply the thalamus. This is the MRI brain done at the level of the ventricles, axial section, coronal section. This is the right hemisphere. This is the frontal lobe, and this is the temporal lobe, and this is the occipital lobe, and this is the central core of the brain, which lodges this thalamus, internal capsule, and this lentiform nucleus, and this is the caudate nucleus. These center part of the brain, they are supplied by the perforators. This is the medial part of the frontal lobe. This is supplied by the anterocerebral artery. And this occipital lobe is supplied by this yellow coded color, supplied by the posterior cerebral artery. And the central part by the perforators. The rest of the brain is fully supplied by the middle cerebral artery. The same on coronal section. This is the posterior fossa section at the level of the pons. This is the pons. This is the fourth ventricle, and this is the right cerebellar hemisphere. This is the left cerebellar hemisphere. The brainstem is supplied by the perforators, whereas the anterior parts of the cerebellum, they are supplied by the ICA. That's the anterior inferior cerebellar artery. The majority of the cerebellum is supplied by the pica. The superior surface alone is supplied by the superior cerebellar arteries, two superior cerebellar arteries. And in short, the middle cerebral artery supplies majority of the cerebrum, and the posterior inferior cerebellar artery supplies majority of the cerebellum. Malignant brain infarction is a very important terminology in stroke, because this is an emergency and a very important radiological finding. This commonly refers to as large area of middle cerebral artery territory infarct. At least there should be more than 50% of the area involved. There can or cannot be involvement of anterocerebral or the posterior cerebral. Sometimes, if the middle cerebral along with anterocerebral and posterior cerebral, all three cerebral vessels are involved, it leads to hemispherical infarct. Usually, this condition produces acute brain swelling due to fulminant brain edema, which leads to acute elevation of intracranial pressure and a herniation and a faster neurological worsening. This is a surgical emergency. Certain areas of the brain, they are prone for hypertensive bleeds. The basal ganglia, cerebellum, the brainstem, and the cortex. In the basal ganglia, the lentiform nucleus and the thalamus, and in the cerebellum, the dentate nucleus and pons in the brainstem. When bleeding occurs in the cortex and the subcortex, it's called a lobar hemorrhage. Usually, it's due to rupture of a medium-sized atheromatous vessel. Coming to the indications, there are only 4 emergency surgical indications. 1, malignant brain infarction. 2nd, cerebellar infarction with hydrocephalus. 3rd, a sizable intracranial hemorrhage causing acute elevation of intracranial pressure. It may be whether in the cerebrum or it may be in the cerebellum. And acute obstructive hydrocephalus. These forms the 4 emergency surgical indications. And coming to the procedures, there are mainly 4 procedures for the 4 indications. The first procedure is hemicraniectomy for a malignant cerebral infarct. That's the skull over the infarcted cerebellum is removed and the dura is open so that the edematous cerebellum bulges out. It bulges out, and this dural defect is patched with a fascia and it is sutured to the parent dura. And this is how an axial CT scan looks. There is a absolute no bone on the right side of the skull vault. This is the 3D picture of a craniectomy patient. It shows the extent of the bone. The bone removal starts, it corresponds to the mid-pupillary line, and it is about 3 to 4 centimeters away from the midline, and inferiorly it's flush with the zygomatic arch, and posteriorly, depending upon the need, we can remove the parietal prominence. And this is how duroplasty looks. The dural defect is patched with the temporalis fascia and is sutured. And for a cerebellar infarct, midline suboccipital incision is made, the suboccipital bone is exposed, the triangular bone below the transverse sinus, this the blue one is the transverse sinus, a triangular bone is removed in the suboccipital region and the dura is opened so that the cerebellum bulges out. This is the right cerebellar hemisphere and this is the left cerebellar hemisphere, and this is the vermis, and these two are the tonsils. In case of infarction, because of the cerebellar infarction and edema, the tonsil gets impacted into the, this is the medulla, the tonsils get impacted into the spinal canal. This procedure will reverse that tonsillar infarction, tonsillar impaction. And for hemorrhage, any hemorrhage, whether it is in the cerebrum or it's in the cerebellum, the procedure of choice is craniotomy and do evacuation so that there is a rapid reduction in the intracranial pressure. And for intraventricular bleed with obstructive hydrocephalus, ventricular drain, that's the external ventricular drain, is the procedure of choice. You put a burrow in the frontal bone, insert a catheter into the ventricle, tap the ventricle, let out the blood so that the ventricular pressure comes down. Coming to some of our cases, this is a large area of infarct on the left side of the cerebral hemisphere. There is involvement of the medial temporal lobe. This is a malignant brain infarct who presented with low GCS. He underwent emergency hemicraniectomy with duroplasty. The brain bulges outwards. That's called a transcranial herniation. Bulges outwards through the skull defect, and there is normalization of the midline shift and better visualization of the basal cisterns, all pointing towards ICP reduction following surgery. This is a patient who developed a parenchymal bleed following thrombolysis, IV thrombolysis for stroke. There's a massive brain hemorrhage on the left side of the cerebral hemisphere with a massive midline shift and going in for subfalcine herniation with no visualization of the basal cistern. The treatment is same for MCA infarction. The bone is removed, that's a hemicraniectomy done, and there is partial removal of the clot is done and duroplasty is done. There is we can see that the midline shift is getting backed and with better visualization of the basal cisterns. Once the edema settles, the brain gets into the skull, and this is how it looks after a few weeks with normalization of the midline shift and better visualization of these basal cisterns. There is gliosis in the previous hemorrhagic area. Is another patient with a cerebellar infarct secondary to cardiac embolus. It's a massive cerebellar infarct. There's an obstructive hydrocephalus because the infarct has blocked the fourth ventricle, and because of that, no flow of CSF, so obstructive hydrocephalus. She had undergone suboccipital craniectomy with a dural opening, and there is some hemorrhagic part of the cerebellum was also removed. The ventricle is decompressed with an ventricular drain. We can see that the ventricle size has come down after 2 to 3 days. This patient improved. This is another patient, hypertensive patient, presented with a right lentiform nuclear bleed. It's a huge bleed on the right lentiform nucleus, with intraventricular extension. This patient undergone a craniotomy and ICH evacuation. This is the surgical track. We can see that small residual bleeds which will settle on its own. This is another patient with a cerebellar bleed. That's a dentate nuclear bleed with obstructive hydrocephalus. He underwent suboccipital craniectomy with the removal of the cerebellar ICH and a placement of a ventricular drain to decompress the ventricles. This patient also improved. So another patient, hypertensive patient with a huge thalamic bleed with an intraventricular extension. This is the immediate postoperative scan, shows that there's minimal intraventricular bleed. This is the surgical track. This another patient, young patient with a hypertension, not taking medicines. This left lenticular ICH. She underwent craniotomy and ICH evacuation. This is the postoperative scan showing very minimal residual hemorrhage near the caudate nucleus, which will resolve on its own. This is a hypertensive patient with a pure intraventricular hemorrhage and mild obstructive hydrocephalus. A ventricular drain was placed. We can see that the ventricle size has been significantly reduced after the drain. When bleeding occurs in the cortex or in the subcortex, it's called a lobar hemorrhage. About 20% of hypertensive patients, they present like this. He underwent craniotomy and ICH evacuation. Craniotomy and ICH evacuation with no residual ICH. Is another patient with a lobar hemorrhage on the left side. It's in the temporal as well as in the parietal region. He underwent craniotomy and ICH evacuation with a small minimal patch residual in the subcortical region with a greatly reduced mass effect. And in the conclusion, in summary, there are 4 emergency indications for stroke and there are 4 procedures, and this is the rationale for the procedures. The first indication is malignant MCA infarct. The procedure is do skull removal, hemicraniectomy and duroplasty. The idea is the brain bulges outwards so that the intracranial pressure reduces. And for cerebellar infarct, do a suboccipital craniectomy so that the cerebellum bulges outwards and the brainstem pressure is relieved. And for a significantly sized ICH, whether it is in the cerebrum or in the cerebellum, do craniotomy and ICH evacuation. It rapidly reduces the intracranial pressure. And for obstructive hydrocephalus and intraventricular hemorrhage, do a ventricular drain, EVD. It rapidly decompresses the ventricle. Most of the time, clinical results are better. Thank you. Thank you for the attention.
Thank you, sir, for standing us with your mind-blowing presentation. Thank you very much. Now I'd like to invite our chairpersons to enlighten the discussion by contributing their valuable points.
Wonderful talk on craniectomy in stroke. The most debatable point would be the timing of craniectomy, when to actually identify and what are the pointers clinically as well as imaging to take a patient for craniectomy.
It's mainly clinical as well as radiological. Clinical is assessment of the GCS is very important. Radiological is the extent of the midline shift. Shift of more than 5 millimeter is surgically significant, and subfalcine herniation and early uncal herniation. These are all absolute indications for a surgery. Usually the malignant brain infarction, it results within 6 to 24 hours. So the first 24 hours period is very crucial.
Elaborate, nice presentation, Mohan. Nice.
Thank you, Dr. K. Selva Perumal, sir, and Dr. P. Gayatri, ma'am, for your guidance in this session. Now I invite Dr. Shekhar Sir, Senior Anesthesiologist from E-Road, to felicitate and present the mementos for our esteemed chairpersons and speakers. Thank you everyone.